Hi, everyone, and welcome. Nearly 200,000 amputations are performed each and every year. The numbers are disproportionately higher in low socioeconomic areas. More specifically, Black diabetics are amputated at triple the rate of others, and we've got to put a stop to these atrocious disparities in healthcare. On the front lines in this effort is Dr. Faluso Fakorede. He's the Chief of Cardiovascular Solutions of Mississippi, one of the highest amputation rates in the country, highest cardiovascular disease rates in the country, also one of the highest diabetic rates in the country. Welcome, Dr. Fakorede.
Good morning, Kim. How are you?
Good. You really caught my attention with the ProPublica article that shared your experience, and it was named the Black American Amputation Epidemic. I want you to share your thoughts of a story that you actually shared in the article about Henry Daughtry. When you first saw him, he was laying on a cot, his legs were swollen, his feet were rotting. The X-ray images showed very poor circulation. He had already had one leg amputated, and now you were going to try to save the other leg. What happened?
Well, Henry's story is typical for most patients, not only here in Mississippi Delta, but in patients who live in what I call the amputation lottery districts of America. And I'll explain that shortly. But Henry is basically 68 years old. He was diagnosed at age 60 with diabetes, type 2 diabetic. So his body doesn't produce enough insulin to, his body resists the insulin that's produced by his pancreas. And what happens is that most of these patients have a low literacy level of basically understanding what, number one, diabetes is. They lack the economic ability to afford the medications that can cost anywhere as high as $6,000. His insulin pump costs $6,000. And he was a son of a sharecropper who lived in one of the poorest districts in the state of Mississippi, Mississippi being one of the poorest states in America. So Henry basically did not have the understanding of what his disease state was. And what that led to is the progression of plaque buildup in his arteries called atherosclerosis. And atherosclerosis occurs at a rate that is 4 to 5 times faster if you're diabetic than if you're non-diabetic. And basically we're born with arteries that are just clean as a whistle, right? And as it progresses, we start developing these yellow substances called plaque buildup. And ultimately it leads to the narrowing of the blood vessels, so you don't have oxygen-rich flow going to those organs. If this happens in your heart, it's called a heart attack. If it happens in your neck, it's called a stroke. If it happens in your legs and your limbs, it's called peripheral artery disease, critical limb ischemia. At its extreme stage, it could lead to buildup of wounds and gangrene. And that's what happened in Henry's case 8 years ago. He was evaluated, was not screened early on in the disease process, and was given an amputation first strategy, which is basically a surgeon telling him that your only option to treat peripheral arterial disease and critical limb ischemia is an amputation. And Henry agreed. He subsequently had complications from that procedure, including a stroke. And I think that was a culmination of his diabetes, and also we see that in patients who've undergone amputations. And so he presented to our hospital with the other leg now having the same pathology and the same progression of disease. And one thing that I tell my patients is that your body produces twins when it comes to this disease. What happens in one leg happens in the other. If you're caught with peripheral arterial disease in one limb, you have to have the other fixed as well, as early as possible. Just kind of like cancer. The earlier you fix, the earlier the chances of successful revascularization, successful survival, and their prolonged life expectancy. So an average person like Henry, after undergoing an amputation, your life expectancy has significantly decreased. 80% of them die within 5 years. And so in his case, we saw him in the hospital. We wanted to do a procedure. there was some resistance in terms of availability of staff. It was the holiday weekend, it was the Martin Luther King weekend holiday. And so I was fortunate to have my outpatient-based lab and my staff where I could just, recruit them at any time during the week and tell them that we have a case, brought him here and successfully opened up his limb. And I have good news to share. We did this in January in terms of his case. And I saw Henry in clinic yesterday, and Henry still has the foot. So the moral of the story is that, one, it's all about screening these patients early, teaching them what diabetes does to their arteries and what lifestyle and dietary modification strategies that he had to take on. He had lost 2 sisters to diabetes. He had 2 other sisters that were taking care of him. The cost to these patients is something that we as a community have to address, because not only the cost of an amputation, but the cost of diabetes itself, and why this is so prevalent in the amputation lotteries of America, which are namely the southern states with the highest proportion or prevalence of African Americans, Hispanics, Native Americans, and indigenous populations, and regions that have the highest concentration of patients who are underinsured, Medicare recipients, and who are also on the lower level in terms of your income, strata. So that's where you see the amputation lottery or the amputation mecca of America.
Yeah, I mean, there's so many, and in your article, you said that it's eerily similar to the slave areas in the South from way back when, that when you look at the high rate of amputations, the maps are pretty much similar.
Yes, it is.
Why is it in those particular areas we're seeing the highest rate of amputations, and we're seeing not so many office-based labs? Maybe they're starting to trickle in, but is it that medical professionals don't want to work or can't work in these labs and they can only work in the hospital? Why are we just seeing major hospitals in these areas and not these office-based labs? Because the office-based labs are notorious for actually saving life and limb.
Right. So unknown to many is that Mississippi once had the 4th largest economic growth and strength in the world at one point. And at that height of that period was during actually slavery. We had, if you look at these maps in these regions, it was basically where cotton was king during this region. So in these areas, you saw a larger population of enslaved, African Americans who were brought over, and the purpose was for wealth and power. And so more slaves than any other state actually existed here in the state of Mississippi. And in fact, it's an enduring legacy till this date of having a Black population of almost 40% of its population. And that is similar in other regions. Now, what you see here in this map is that these patients, the highest concentration of African Americans, also has the highest amputation rates per Medicare population. So you've seen patients who are Medicare, so older actually African Americans, who are like Henry Dostry now, who's 68 and older, who again amputated at rates that are as high as 4 to 28 times higher if they're diabetics in these regions. But sadly enough, they also have the lowest number of revascularization rates. And for your audience, revascularization means that opportunity to go and open up that clogged artery. So this artery, to turn it from this back to this, using a procedure that's minimally invasive. We call that revascularization. It can be done either minimally invasive or with bypass surgery. And these patients are offered the lowest number of revascularization opportunities. So the question, to your point, is it because we have the lowest number of physicians that look like myself who perform these? These are high risk procedures. They're very skilled. They require a skill set where you can treat above the knee disease and below the knee disease. In our case, it's multifactorial. One, not a lot of physicians during their clinical training or medical training are enticed or encouraged to come to areas such as the Mississippi Delta, right? You come out of training, you go to a big academic institution, so bigger cities, where you have more resources available to you. You have the ability to build a care coordination team, a multidisciplinary team that has at your beck and call an endocrinologist, a sugar specialist, an infectious disease specialist, a wound care specialist, a podiatrist, a vascular surgeon, a general surgeon, an orthopedic surgeon, and you have access to all these centers and providers. Well, in the Delta, that's not the case. You have pockets of hospitals that are all within, distances, right? And you have patients who reside in a catchment area where they have to travel 2 hours to get to all these big facilities. So they depend on local hospitals. And some of these hospitals are either, either community-based hospitals, critical access care hospitals, and some of them are for-profit hospitals. And they lack the resources, they lack the multidisciplinary team. Specialists such as myself are not incentivized to come to these regions, right? They incentivize a primary care doc, a dentist, and psychiatrist, a pediatrician, but an interventional cardiologist who wants to come and set up shop by himself and set up a team is not incentivized. There's no loan forgiveness for someone like myself who carries $200,000 to $300,000 debt. And this is where you have the largest concentration of the cardiovascular disease burdens, right? And it's not just here in the Delta, think about it. It's Appalachia, it's Kansas, it's Oklahoma, it's New Mexico, it's California, it's Texas. And so what we are lacking is outpatient-based labs that are nimble and responsive to the patient population in terms of access to quality care. When the patient walks into our outpatient lab where we can set up shop and treat their disease states, irrespective of your insurance status, irrespective of your skin color, irrespective of your economic status, irrespective of what barriers you might face from a social determinants of health standpoint, right? We try and facilitate, accommodate, bring them in. They don't have to deal with a big hospital system. It's a small, contained system where it's the same doctor who sees you in clinic who's taking care of you. So there's patient satisfaction is on top of the charts. There is throughput of the patient where they come in 30 minutes, they're on the table and off the table and home within 4 hours. And also we can address their social determinants of health needs with a clinical staff that is just right next door. And we can now come up with a follow-up, date for them, so they're not lost to care coordination. When you have all these different doctors, people are lost in that silos. And you also have access to quality care. I can use the devices and the treatment tools that the president of any country would want if they had peripheral arterial disease in my lab. That is what I bring to the table. And another important factor that I bring to the table is that I reflect the community I treat. I'm an African-American physician here in the Mississippi Delta that has one of the highest concentration of African-American patients who have cardiovascular disease. I also happen to be less than 1% in my medical community. There are not a lot of Black interventional cardiologists, and I am less than 1% limb salvage specialist. And so the opportunity to come here and speak truth to power and talk to what are the research needs that I can incorporate into my lab and enroll African-American patients in clinical trials. I can actually teach them what the lifestyle and dietary modification needs that are important for them to thrive from a preventative standpoint. And they listen because you speak at their level and you understand their challenges, both from a healthcare standpoint, economic standpoint, transportation standpoint, from access to good foods, quality foods, and understanding the food deserts that exist out there. And then lastly is addressing, the elephant in the room, racism. They're very comfortable sharing some of their thoughts. And I have no preconceived notions from the mindset when they first walk into when they leave. So that's what's been very successful. And having an OBL can actually be something that others can take on in different neighborhoods that reflect such challenges.
Right. And it's not, this isn't rare. And I want people to really understand. I even experienced it when I went to a hospital in Louisiana. I was observing a doctor with a patient. The patient was a Black American, diabetic, cardiovascular disease, peripheral artery disease, all of the above. But when we looked at the fluoroscopies, I've seen this doctor in particular do a lot more than what he needed to do in this particular case. And yet he told the patient right in front of me, hey, sorry, nothing we can do. Next step is amputation. And the guy burst into tears and he, just weepily went out of the room. And when he was gone, I said, hey, doc, are you serious? I mean, I've seen you do more than this. Why would this guy? Oh, he's not going to take care of himself anyway.
Right.
He's not going to stop smoking. And I said, well,
he's non-compliant.
He's non-compliant. That's the number one thing I hear all the time. And that's BS. It is because, a doctor can actually help coordinate, facilitate the resources necessary to help these patients.
Right.
And that's, even what we're doing with The Way to My Heart is going out there and infiltrating these communities and trying to love on them and provide them, find out what they need, how they need it, and going out there and literally being boots on the ground and making it happen. But the fact is, the reality is real. And you mentioned the Medicare numbers. Dr. John Simpson, who is the godfather, as you know, of balloon over the wire, angioplasty. Everyone's heard of angioplasty, where they push the plaque aside with the balloon. He told me in an interview a couple of years ago, and he said, just look at the Medicare numbers. Everyone can look at the Medicare numbers, and you see the disparities are in fact real. And yet nothing is being done at scale. So something needs to be done. Correct. Where do you suggest that people start?
Correct. Well said. In terms of the disparity, where we start is first with addressing things like statistical discrimination, which is what you basically just clearly, eloquently described. If my mother were to walk into my office, that would not be in play, right? You'll treat every person that walks into your office as a family member. And you have to carry that apron of humility to serve others and using everything in your power to make sure that the best outcomes is achieved for that patient. So when it comes to a pandemic like PAD, and I call it a pandemic because peripheral arterial disease afflicts 200 million people worldwide and 21 million Americans. It's actually the most prevalent, deadly, costly, and debilitating disease that most Americans have never heard of, which leads to about 200,000 amputations every year, 130,000 of which are performed in diabetic populations. So that's about 65% of patients. 1 in 3 people will lose a limb due to PAD and diabetes within the next 30 seconds. That is unconscionable, knowing that 90% of these patients are not offered a preventative strategy before placing them on the table to use a blade and cut off their limbs. And it's unacceptable and criminal if you think about it, because you are basically turning the hourglass on their life expectancy once you take off that limb. And if you know that there is a preventative strategy or another strategy to save this patient, why not sit down with them, explain what their options are. Things like, minimally invasive procedures, even bypass surgery is another option. But explain to them that if we exhaust all possibilities, then amputation is the last thing that they can potentially face. A smoker, if you were to walk a smoker into the room and tell them that your life expectancy, buddy, is going to be decreased by 8 years, and the doctor is going to walk into the room someday and chop off your limb. So you know what? Call your mom, call your daughter, and call your wife and tell them that, hey, this cigarette is more important than the 8 years that I potentially can save if I were to quit smoking, versus I'll continue smoking and in 8 years I'm having that stroke, that amputation. Half of them will start thinking differently. And it's not about quitting once they just, cut it down from 20 to 1 cigarette. It's seeing them through and loving them through the process and going out.
Micro steps is what's key.
Right.
You don't need to so cold turkey, but it's not required.
Correct. So understanding the risk factors, it's diabetes, it's nicotine exposure, not just smoking, dipping and chewing, right? In underserved communities and in minority communities, most people actually dip and chew than they smoke, and we don't reflect that in our research. High blood pressure, high cholesterol, obesity, chronic kidney disease, anyone over the age of 50 who has any of these major risk factors, or anyone just over the age of 65. These patients have to be screened early on, but our medical community has also failed. The US Preventative Service Task Force, which is the body that comes up with screening guidelines, has refused to recognize these at-risk populations, especially minorities. And they refuse to incorporate that in the vascular screening guidelines so that CMS can reimburse primary care doctors who see majority of these patients. And so if those doctors are not incentivized to screen these patients early on in the disease process, then the patients suffer and we pay that costs our healthcare system close to about $300 to $400 billion a year. And guess who foots that bill? You and I. 80% of that bill is paid for by taxpayers. It's criminal. I don't understand it.
It's so upsetting to me that when more than 50% of people who suffer a heart attack have normal cholesterol, and yet it's still the determining factor as to whether or not a doctor, a general practitioner, does further testing on you. That's really sad. My dad almost had a heart attack, 95% blockage in his circumflex artery. They were going to blow it off as just indigestion. I pushed a little further for an EKG, which they found an abnormality, but he had normal cholesterol. They looked at his chart and said, we don't need to test further. It has to be indigestion, because he would have higher cholesterol numbers if in fact it was something to do with his heart in particular. It's really sad when all they need, if they just adopt even a new piece of technology, a new smart stethoscope. Several of them are available. HD Digital as well, HD Medical Group has one, Echo has one. They're low cost. We got to get those on the front lines and not just rest upon these antiquated policies at hospitals. We got to change the rules. And you know, if every single doctor, if every single general practitioner just took their 2 fingers for everyone over age 50.
Take the socks off.
Take your socks off. Just take the socks off. Feel my leg.
Socks off and check the pulses. Right. So that's mandated in my clinic. Anyone who walks through comes in. If you are at risk, we screen and we check your pulses. If you know, I'm a cardiologist at first. So anyone who comes in who has risk factors, it's a comprehensive screen because this is a polyvascular disease, right? So awareness of PAD itself is the problem, Kim. If you really think about it, we lack awareness on a patient level, provider level, and community level. And then what's also lacking is that the research that we've done with PAD and all these trials, guess who's lacking in all these trials? Minorities, women, right? And patients who have majority of these risk factors, who might have, chronic kidney disease or end-stage renal disease. They're lacking in these trials. So when we come up with a medicine that we say, hey, this is the new technology or new, medicine to treat, we have to be cautious because it can work in one population. But if you have not utilized that in the Delta, where majority of my patients do not have the broadband access for telehealth and do not have smartphones, it's not a practical solution for them, right? Most of these patients do not have the transportation means to be able to get to centers that even might be able to provide such services. And from a state level and from a federal level, how do we address that? How do we work as care coordination teams? How do we incentivize that process so that we can all meet in the middle to be advocates for them? Just as you advocate for your dad, most of these patients do not have advocates at home. Most of these patients, I mean, if you look at the history, most of these patients are either, they live with intergenerational households where kids are taking care of the adults. And so that's why we target schools now with our awareness campaigns so that maybe some of these kids can go home and educate their patients about cardiovascular disease, to teach them that plaque buildup doesn't just affect your heart, it can affect your neck, it can affect your kidneys, it can affect your limbs. Teaching them what diabetes is and teaching them what high blood pressure is and teaching them what high cholesterol is and why we exercise and the importance of it, how to eat right, what the food desert is, right? Why do we have a lot of McDonald's and a lot of these, restaurants out here and we don't have a lot of, healthy access to healthier options.
Well, we have to empower these places, the McDonald's, the gas stations that have mini marts, to bring in greater food, maybe up the price on some of the other stuff, lower it so that they can lower the price on some of the healthier goods that they can bring in.
Correct. But you don't know what you don't know. And that is exactly the problem here. And in other places, even both my parents are diabetics, but the fact that I had to really counsel them on why they need to see both their primary care doc and an endocrinologist, for instance, right? Once or twice a year, you need to see an endocrinologist. Why? Because that is the specialist who can work with your primary care doc to make sure that your sugars are better controlled. While over here, we do not have an endocrinologist in 100 to 110 mile radius.
Are you kidding?
And we have ranked 1 or 2 in diabetes since 1990 to last year. So that's the problem, right? You don't have access to all the quality measures, interventions, or providers that you need. We have the lowest number of physicians per capita here, right? So where are all these doctors? And that's why places like ambulatory surgical centers or OBLs, outpatient-based labs, can be nimble and have that multidisciplinary team actually within the confines of that building, and they can care that you can coordinate care. And we welcome hospitals to collaborate. It's not, COVID has exposed this inequity, right? Look at COVID-19 now. A lot of care is being shifted to the outpatient because they're either overwhelmed or hospitals are actually shutting down. That is you see that trend as the economic hit to our community even gets worse. And so I implore people to take advantage of preventative strategies for upfront, right? Don't be a statistic, to seek a second opinion, including with amputations. And if you're offered an amputation for a strategy, seek a second opinion. And 3 is to policy action. How do we restrain the heartless? So we've worked on policy action to help, challenge some of these antiquated policies and systematic issues that plague our healthcare system. And we're working with the PAD caucus on the Hill through a bipartisan effort led by Congressman Donald Payne Jr. and Congressman Bilirakis. And we want to disincentivize an amputation first strategy. We want to increase PAD awareness. We want to incentivize a multidisciplinary team approach. And 4, we want to have quality measures so doctors can publish their data and patients can go and say, okay, I want to go see this doctor because he's saving limbs and saving lives. That's what we want to do.
And you mentioned COVID-19. I think that's such a great point because people in the Black community are actually having the more serious complications at a disproportionately higher rate. And they're not seeking the care early enough as they need to in order to get to these hospitals. But you know what? Even if they do go to the hospitals, they're at higher risk because, one, they're going to have their legs cut off a lot quicker than in an OBL. Of course, they have the mistrust because of that. But number 2, in any patient, and even if they are well and they don't have COVID at that point, they go to these hospitals with these comorbidities and they're walking right alongside someone who has COVID, boom, they're done because they're at higher risk of the deadly complications. Right. So I really think that you have something. We do need more of these outpatient facilities if we want to truly make a difference for people who are diabetic, who have hypertension, who have cardiovascular disease, and who have peripheral artery disease. COVID shed light on the fact that they can't be treated in hospitals, and even worse, they're not being treated. We had a patient who was going to a very well-known hospital in Chicago, and the doctor said, hey, yes, your foot should be treated right now. It should be treated, but we can't. We're tapped out with resources. We're focused on COVID. So you know what? Give us a call in 3 weeks, and I'm not kidding. Give us a call in 3 weeks, and we'll just amputate. So we called up another doctor, and I was like, in an OBL, and he was 2 hours away from him, and I said, we got to do something. We could save his leg now. And they drove 2 hours, and he saved this man's leg. And
guess what? The healthcare system doesn't get about that story, because that patient had critical limb ischemia. So the example for critical limb ischemia is a heart attack. They're basically equivalent. When you're having a heart attack and you call 911 or you call a hospital, do you ever hear the person on the line say, you know what, why don't you go take an aspirin and call me back in 3 weeks? And then we'll determine if you're still alive or not. And if you're still alive, we'll do bypass surgery on you. You've never heard that, right? It's no, ma'am, take an aspirin, we're calling an ambulance and coming to get you. Well, critical limb ischemia, again, the lack of awareness, right? 1 in 3 to 1 in 4 providers actually understand that they're 3 to 4 times higher of having a heart attack, a stroke, or death. Their complication rate, if not treated, majority of them will die from some kind of infectious etiology, sepsis, hyperinflammatory state is already raging. So you put them in the context of, having a critical limb ischemia and ignoring their care because we have these guidelines that some state board might release and say, well, you know what, if it's not COVID or if it's not heart attack, don't treat. Well, you're missing other critical diseases. Yeah. And that is where we fall in. And so having a center where you can actually treat these patients, because time is muscle. Time is muscle. And if they don't treat that disease, not only is that affected leg gonna have an untoward outcome, the other leg as well.
You said there's progression.
And so you're, and then the cost of our healthcare system is only even magnified by that. And so with COVID, it's addressing issues as who are these patients? How can we safely treat them? What facilities are actually safer to treat these patients? Let's look at outcomes when it comes to infectious rates, complication rates, opportunities for a patient to have less exposure to the medical community, right? If you go to the hospital, you check in, you go sit in the waiting room, then you go into the facility where you're treated, then you have to wait in the holding area, then go upstairs to the floors and then see 2 levels of nursing and then get discharged and someone else is so you're exposed to multiple people who are quote unquote frontline, right? And those frontline workers actually have the highest exposure from a viral load. Mm-hmm. So as a patient who's immunocompromised, you're even more at risk. And so that's something that is just not thought out, from a public health policy standpoint. And we need to champion and actually challenge some of those restrictions.
I agree. I mean, we need to test earlier for one. I mean, it's critical. I mean, the COVID did shed light on the fact that there are major flaws in terms of prevention, diagnosis, and treatment. And there's no excuse anymore. Innovation is moving at the speed of light. It's lowering the cost and access to these newer technologies that can help the doctors on the front lines. So there's no excuse as to why these patients are not being treated. Instead of just doing a basic lipid panel, do an advanced lipid panel, dig a little bit deeper. Let's make that standard. Let's make, feeling, for a bruit. Let's make feeling for an aortic aneurysm. Let's make feeling the leg pulses standard in every single appointment. It costs them no more.
Correct. And those intractable barriers are still in play in spite of all the technological advances, right? You've been to all these conferences and you walk in and that's the highlight of the conference is, hey, listen, this is our new tool. This is our new product. This is our new medicine. But guess what we haven't addressed? We haven't addressed the population that actually really needs a different form of intervention, 1. And 2, we haven't really addressed some of the social determinants of health that prevent them from having access to that device that you're touting. Because the presumption is that whatever device you are, let's just get a rep and let's just send that rep to all the hospitals in America. Therefore, everyone's going to have access. No, not every limb salvage specialist is, engaged in all those hospital settings. 1, 2, the knowledge base of those hospitals from start to finish as to how to prevent things in that paradigm, right? At what patient really needs a device intervention versus medical therapy, supervised exercise therapy, checking, their A1Cs and their advanced cholesterol panels, those things, and then going to their homes and seeing how they live, right? I mean, how do they even live as a diabetic? Do we know that? Do we know how they throw parties? Do we know how they, how their kids actually even survive having a parent who's a diabetic and the kid's not being a diabetic? How do they cook? Those are things that are very important. because all the devices in the world has led to a 32% reduction in cardiovascular disease over the last 2 decades. But guess who hasn't seen that benefit? People who reside in that map that you and I just showed. They haven't seen that benefit. And that benefit, we've only seen an increase in amputation rates in our diabetic population by 50% over the last six to 8 years.
Yeah, it's crazy.
Honestly,
I think that even in those communities, and one thing I'm going to put out there, because if anyone who can create change and help in the policies, I'd like to see micronutrient testing. It's a new and upcoming area. Micronutrient testing done in these communities and offered for free for everyone in these communities. Let's start there. Let's start early, and let's start nipping in the bud, finding out what are your deficiencies in terms of vitamins and minerals, and let's work with them independently and bring the resources they need there in order to improve it and show the difference. And I think that that could be huge. And in the long term, I think we're going to see lower numbers, but you got to start somewhere. Let's start sooner. Let's not wait until, you know, the diabetes sets in and the cardiovascular disease sets in and their arteries are already mucked up. Let's start a lot sooner. And I know we can. And you mentioned you're starting with, you know, with the kids to educate, you know, them about their parents, but let's also start providing resources to start helping them to prevent in the future.
absolutely. Absolutely. Our schools, you know, and what's in play is all stakeholders are in play. Not only the churches, but the schools, the policymakers, and community navigators, such as yourself, right? Everyone is in play here. It's going to take that whole village to change that mindset and to change outcomes.
So how can patients actually take their health into their own hands and know, and this is so important, back to the amputation point, to know if their doctor is actually putting them on the course of long-term walking, right? Long-term patency, or actually increasing their chance of bypass and amputation. I mean, the problem is that there is no resource available that says this doctor causes trauma with a heavy hand and tends to cause multiple perforations and dissections, or, you know, this doctor tends to give up quickly on the patient and sends them straight to bypass or amputation.
Right.
There's nothing out there. What can they do? How can they take their healthcare into their own hands? What questions can they ask in order to know the difference? Because their GP's just going to send them and say, hey, I'm going to send you, here's a referral to my best friend.
Right. So, you know, unfortunately, the one thing that we need to all try and do is to be more informed before we can transform. And information takes not only reading, but becoming more literate about certain things that, you know, most of us probably have not thought about. So one, when it comes to your risk factors, you have to know what your risk factors are. So one, if you are over the age of 50 with a history of diabetes or nicotine use, or if you've had high blood pressure, high cholesterol, if you've had a stroke or heart attack, or if you've had coronary disease with a stent in your heart, if you've had kidney disease or strong family history of heart disease or peripheral arterial disease, if you've been told you've had poor circulation, if you've been told you've had osteoporosis and gout, but in spite of being treated, you're still having pains in your limbs and your legs. If you look at your limbs and your legs and you have diminished hair growth and you have cooler extremities one over the other, your color of your skin does not look right, one looks darker than another, you walk and you have exertional symptoms or symptoms at rest where you have paining, burning, you have, you know, rest pain or exertional pain, or you have that burning, tingling, and numbness that persists in spite of everything you've been offered. If you're put on blood thinners at all for any reasons for poor circulation, you need to go have your limbs screened for peripheral arterial disease, full stop. And how you go is you go to your primary care doc, you say, hey, listen, doc, I'm taking off my socks and I need you to check for peripheral arterial disease. Can you please perform either an ultrasound or ankle brachial index or some kind of anatomic testing to test your circulation? That's the first thing. Second is to now, if they refer you to any doctor, one, you have to kind of do your research. And what I mean by that is not only ask the physician, what are my treatment options? What are your success rates? What are the complications? How many amputations have you saved? Are there referrals to patients that I can talk to who you've treated to see? Once you start getting blowback on all those things, then there is a signal there. There might be problems. So then it's going to ask other people in the community who have some insight to medical knowledge, or calling people like yourself or myself to say, hey, I live here in Missouri, I live in New Jersey, I live in Colorado, and I've heard you speak about preventing amputations, and I want to know if there's an amputation prevention specialist in this region. And that's what we need. We need a centralized place that patients can call, where people can offer providers who are willing to share their data. And that data has to be publicized. So they can see what faculty rates are, they can see what everyone else's rates are, and they can say, well, in this region, that's the guy to go to. In that region, that's the guy to go to. He works with wound care specialists and diabetic specialists that also have great numbers in terms of amputation prevention. That is what's needed. Until we can centralize that, it's going to be very challenging, other than just having these, discussions on preventative strategies, identifying your risk, knowing what the treatment options are. That amputation should not be your first option. Seeking a second opinion and being bold to request that. In certain communities, there's this fear. There's the fear of the white coat, right? There's the fear of the doctor. Well, guess what? That fear is going to lead to your early death if you get amputated, because 80% of the time you will be dead in 5 years. That fear will lead to your next heart attack within the next 2 to 3 years. That fear can lead to a 30% mortality within 30 days of having an amputation. That fear will lead to 95% having chronic pain syndromes after an amputation. And that fear will lead to your family members having to bear that burden from an economic standpoint. They cannot afford that.
And I add the what you were saying about what to ask your doctor. Also, I mean, the new one today, can you revascularize a diabetic foot? Can you go into my foot, into those small vessels? Right. I hear this all the time. My doctor said that I can't be treated below the knee because my vessels are too small. Find a doctor who doesn't think your vessels are too small. Right. There are doctors that actually specialize in those small vessels and can revascularize that pedal plantar loop that is so critical in diabetic patients. Ask the question before they do any procedure. Ask if they perform multiple approaches. Do they just come down from the top, or do they have the ability in even the same procedure to come up from the bottom if they can't get through the top?
Unfortunately, that's we're addressing that too within the medical field. We're a very fragmented society. There are surgeons who treat this disease. There's interventional cardiologists, interventional radiologists. And in that training spectrum, especially in fellowship programs, a lot of fellows are not exposed to that modality where they can go from above and below the knee, and they have to take advanced courses. And so we try and encourage them to come and shadow and come to our labs and see how we treat them from both above and below the knees, and what your options are in terms of techniques to go and treat both pedal disease, infrapopliteal below the knee disease, and above the knee disease. Once you have that mindset across the spectrum, so surgeons have to buy in, interventional radiologists have to buy in, and interventional cardiologists, we can produce more specialists in that realm. But we just have not yet figured that out, and we're still trying to work and build a coalition to try and build these young and upcoming docs to have the same mindset. And I think that will come. I mean, everything, just like everything, social justice now, everything's intergenerational, right? We will see a change. Until then, they have to understand that there are people who can treat what one doctor cannot treat, and you just have to seek and find that person. And you need an advocate. See, most of my patients do not have advocates. Most of my patients have an elementary school education. And so when they're told something, it's yes, sir, yes, ma'am. And I tell them that should be out the door when it comes to your health. It should be out the door because we cannot checkmate your life just for the sake of being polite, right? Southern hospitality is out the door when you're being told that amputation is your only option. I want that. I tell them out the door. We find another person. We find another provider. And so we need to not only address policy, but we also need to address the training of our providers. We need to encourage more minorities into the pipeline of medicine at a very young age. That is something that I'm very passionate about. We need to have these doctors believe that, you know, there's some cool docs doing some cool things in the world. It's not just sports, it's not just entertainment, it's not just, you know, finance. There are other ways you can get in. And if you know the social determinants of health spectrum, you can help address different facets of the social determinants of health, be it in the educational realm, in the transportation realm, housing realm, in income equality realm, or in terms of addressing the social context issues that actually plague other than healthcare system.
I want to get to some questions from patients. We have Catherine. I think you pretty much answered her question about how do we advocate for the change of medical best practices so more patients get the appropriate screening and doctors offer all patients all options instead of pulling that non-compliance card.
Yeah. As I've said, you know, that is more.
Like the way she
Yeah,
phrased
that is more. That's a great question. One, we're going to do our part because you can, you know, you have to restrain the heartless. You know, I tell people that, you know, the thing about judicial decrees and policy is not, I can't change hearts, but I can restrain the heartless. So if their policy action to mandate vascular screenings of at-risk patients, that's a win for us. And so that mandates all providers to do that. That, you know, CMS will approve of that, and we will have a way for, irrespective of where you are in this country, to have you screened at an earlier age. It happens for cancer. We do it for breast cancer. We do for other types of cancers. We should do that for peripheral arterial disease, which carries an economic burden that exceeds all cancers, by the way. So that is it. It's important to our healthcare dollars. The second piece to her question is that, you know, how do we advocate for patients' families to understand some of these nuances? Is that, you know, they have to know what the numbers are. What are the numbers? What are the amputation data in our region? And why, if it's so high, you have to seek care maybe outside of that region. That is another thing to think about. Or see who's trying to make a change or effect policy change, or who's the specialist around that region who can help direct them to someone who can provide limb-saving strategies. But preventative strategies is your best solution. Diet, exercise, know your numbers early on, prevent yourself from progressing to that critical state.
You know, it's tough for sometimes these people then when every single rehab program available is hospital-based and requires so much time and transportation to get there. That's why only 20% of those who qualify actually take them up on their offer to go to a rehab program that's 12 weeks long. And even worse is only 50% of those who attend those programs actually complete them. And those who follow the guidelines that were set during the 12-week program, they don't even follow them once the whole program's done. And even more is they've started these remote programs that that they require all kinds of technology in order for these patients to participate. Are you serious? Like,
that takes away 65 to 70% of my patients because they cannot participate in such programs.
No. Right. And even more is that they don't fit into their lives. They don't understand their style of living. Right. Everything, if you want to create long-term change, you have to infiltrate their life. You have to fit into their schedule. You have to understand what they eat and how they eat, and slowly with micro steps, guide them in a healthier direction and incentivize them and reward them for every step they take.
And that's where great nursing, community advocates, you know, I've been blessed to have a great team around me. You know, everyone always focuses on me, but actually my team deserves a lot of the credit, not only from a technical standpoint, but interpersonal competence is key. And so when you have a great, you know, nursing and medical assistant staff who are they're involved in the community advocacy portion, right? They love the community advocacy portion as they do their jobs within here. So when we go out to the community, those are people that actually get calls. They get called on the weekends and they see, all right, hey, listen, I just spoke to this person and they told me that this is the treatment strategy. You represent Dr. Fakorady. Tell me what you believe. And they delve into the lives of these patients, understand their restrictions, under their strengths, their weaknesses, some of the things that the barriers to care. And so we try and help open the lens of others to see what's going on with these patients. And the second piece is the state. Mississippi, for instance, 570,000 uninsured. if you look at these patients, majority of these patients are the ones who carry that cardiovascular burden here in the Delta. But even the Medicaid population, Medicaid does not cover for prosthesis in the state. Most of the Medicaid recipients cannot even go see an endocrinologist in the state. And we have the lowest number, one of the lowest number of endocrinologists than compared to any other state. So the barriers are just layered upon layered, and their medications are restricted, right? How many meds can they have? And they have all these polyvascular syndromes. And so it's just at some point they give up, they give up. And so if you don't have that person to love on you, to say, hey, listen, we will try and get you there. We will try and have solutions to your medicines. We'll have solutions to transportation. We'll have solutions to, we just need you to just have faith and hope. So it's kind of like you becoming this hope dealer, right? I always tell people, you got to deal hope. You got to sell hope to them, right? Try and give faith, because at some point, that's all they want. They want a fighter's chance. That's all they want. And then that's all we can provide. So we have a lot to address, but that's an important piece to the puzzle.
And Myrtle wants a little hope. She says she's dealing with pain in her left leg in the calf up. How will she know if she has a blockage?
Right. So one, she needs to have an ultrasound or an angiogram of her legs to it can be a CAT scan angiogram, called a CTA, to see if she has any blocked arteries. The second thing we need to know is her risk factors, to see if she's had any chronic back pain, radiculopathy. Not everything is PAD. Radiculopathy can exist where you can have spinal stenosis, or people who have chronic back pain who have nerve damage to their legs and their calf. Is it a bone issue? So I tell people, it's not just the plumbing. Could it be the cement, right? Is the structural damage to the underlying bones? That's after you rule out issues with plumbing. And then the other piece is diabetic neuropathy that exists in spite of being revascularized. So about 60 to 65% of patients with PAD will have some form of neuropathy even after the major vessels are revascularized. Why? Going back to your earlier point, there's a component of ischemic neuropathy that occurs due to the lack of revascularization of the very small vessels. And that chronic pain syndrome, it manifests, and that has to be tackled. Two, diabetes. If you're a diabetic and your sugar is not controlled, it damages your capillaries, your nerve endings are shot, you start losing sensation, and those signals that should send out signals are impaired, and you have neuropathic signals that are going down and causing worsening pain. So your diabetic neuropathy has to be addressed. It's one of the largest unmet needs that actually, if not treated, it correlates with the extreme disease state of PAD, of diabetes, and that itself can lead to amputations.
And Jill, right along the same lines as Jill's question, she has type 2 diabetes. Her doctor diagnosed her with neuropathy in her legs. She says excruciating pain keeps her up at night. I have a pain management doctor, but nothing seems to help. I saw a post on the Way to My Heart's page about it, that it could be artery trouble, but I went back to my GP, asked him to do other tests. He just gave me another pain prescription. She said she belongs to another group on Facebook, Diabetic Neuropathy, and they don't talk about artery problems. So how do I know I can't live with this pain anymore? Do I have to?
No, you don't. What she has to do is, one, maybe seek another GP who's willing to do, some kind of scan of her arteries all the way down to her foot, and refer her to a vascular specialist. She can request, can I see a vascular specialist who can do a comprehensive assessment of my arteries and of my veins, to look at both the arteries and the veins, to see if there are any issues there. If not, then do I have some kind of nerve conduction study to determine if there are other issues that are going on. And just quite frankly, some of the pain medicines that are there for neuropathy are just not, the efficacy of these meds are just not, the side effects actually are worse than the actual benefit of the medications and the cost. So that's another challenging aspect to care that we have to address. But she has to seek out either a vascular specialist or demand for anatomic testing of her arteries and veins.
And one thing you mentioned ultrasound a couple of times, a lot of these doctors, and I think this is important to mention, is that if your doctor, your general practitioner, only offers you an ABI test, an ankle brachial index, and you know it's that because it has blood pressure cuffs they put on your legs and your arm. If it comes back normal and you're diabetic and you're still feeling pain in your legs that's unexplainable, still being brushed off as neuropathy, know that you can have a false normal.
Absolutely, absolutely. That's a great point. You know, diabetes is one of those things that you have to be called. Patients who have kidney disease, and patients who have, you know, basically advanced age, you know, over the age of 65, patients who have calcified vessels, so a lot of calcium. What you have is that you kind of miss about 30% of these patients using that modality. And so I'm very suspicious in a place where I have a very high prevalence of diabetes, dialysis centers. You know, every city or town has a dialysis center around here. So chronic kidney disease is prevalent due to high blood pressure as well being prevalent. I have an aging population, highly Medicare, right? So these patients need a different modality to assess. That can be in addition to the ABI or separate from the ABI. And that's why I recommend that they have segmental pressures, and then additional, we do ultrasounds to make sure that we can have a functional assessment, you know, and checking their toe pressures with, you know, seeing what their ultrasound, their ultrasonic vessels look like. And if anything is in doubt, you can then escalate that to the next level of anatomic testing. Maybe it's a CT angiogram and MRA, or angiogram in a OBL or angiographic suite.
And one more question. I know we've taken up so much of your time.
No
Appreciate your time
no
so much. This has been incredibly educational. We have Bill that has a question. He says, I didn't realize revascularizing was an option. Why is my doctor only offering me bypass? You know, I go to an HMO and I'm at a loss as to what options I may have,
Right.
because I am limited. I'm in this HMO.
Right. So we have what HMOs need to realize is the cost. The cost of surgery versus endovascular revascularization has been shown. It costs a hospital system and the HMO system more money to perform surgery. Now, bypass surgery, in terms of a patient who has a blocked artery that's extensive and might be the only conduit for them, for certain patients, that is the only option, is bypass, not amputation, bypass surgery, where you're basically bypassing the blocked arteries. But for the most part, patients who undergo minimally invasive procedures, it's lower cost, it's, you know, time to get, you know, spent in the clinical setting. It's talking about hours versus days. And you're talking about cost to not only the hospital, to the clinical or HMO system, that is way lower. And you have good outcomes long-term. What we need to discuss with that patient is, one, 50% of all Americans are offered a surgical approach first. And when it comes to amputation, if you live in a high amputation area, 90%. So that is the mindset. Then that is that unacceptable mindset that we need to change. Two, you need to explain to your HMO that there are doctors who are doing procedures out there that cost less and they're saving limbs and saving lives in the process. And we need to know if that HMO is responsive, and if not, he needs another option. Just like you have options with doctors, you know, sometimes we have to, you know, bring that to the table, and have your doctor call them. And you know, so an advocate has to call that HMO and really explain that, because that might be an educational opportunity for that HMO to learn more about this disease state that some of them are just not educated about.
Well, you have one HMO that I actually I observed for a couple of days, and they have interventional radiologists, interventional cardiologists, and vascular surgeons, and they're all actually fighting for the same patient. So it's almost a luck of the draw. You as a patient, who your GP is BFFs with.
I know.
And whether you are going to have an amputation or whether you can have your leg saved. I mean, it's unbelievable that there's no consistency in care, and that minimally invasive procedures are not at the forefront. They're not given the higher priority. And I do think that policy-wise, from a payer perspective, and even higher than that, I really think that, yes, you have some interventionalists, interventional vascular specialists that are in these hospitals that have the skills to be able to revascularize the foot. Getting to them, who knows? They don't want to actually say to their other interventional friend that may not have that skill that, hey, you know, you should send me all your patients you can't treat.
Correct. I know.
But they really should. And that should be a hierarchy. We really need to put pressure on these hospitals to give priority to doctors who can actually revascularize the foot. If one interventionalist can't do it, send that patient to another interventionalist, even within the same hospital system, who does have that experience, versus sending them to bypass or sending them to amputation.
Which goes back to my question, you know, remember I told you part of the proposal in addressing this issue is to publish your numbers, because you can see who's doing what. We can have a quality measure in that bill that actually will show you and highlight, all right, this is the hospital. Hospitals will need to publish their amputation rates, revascularization rates, who's doing what type of revascularization. And then you can tell, looking at those numbers, well, this guy is actually, you know, doing the right job and saving our healthcare dollars, and this person is not. And this is who we need to talk to. And then we need to figure out how to remedy the problems, right? It's not just ignoring those centers. It's those hospitals and those centers have to have a structured way to be remedied. And that is them enrolling in programs where they can go and observe and learn how to transform their programs to be of service, quality service to the patient, care coordination plans in play, and with great outcomes, and serve a higher purpose. And that's what we need to do. This whole good old network club just needs to go away, because communities are suffering disproportionately. And it's, unfortunately, it's the African American, it's the Native Americans, the Hispanic population that have beared a lot of this burden. And so that proverbial, you know, knee on their necks for a while and for years and decades, it needs to end. And it ends by calling them out for who they are and what they do. And that's the purpose of this. Speak truth to power on the topic.
And my final thoughts, you and I together, let's start our campaign, publish your numbers, and let's get patients, all of you patients that are out there and you're watching right now, tell your doctor, publish your numbers. Dr. Fakorede and I, we are going to encourage all doctors to publish their numbers, and we're going to post them together. Let's publish those numbers. Let's get this information out there. Let's give the patients a resource together to show them that there are doctors that can do it. And let's inspire more doctors to want to get their numbers published as well.
Right. And my final thought is, one, you know, we've shown that publishing your numbers by decreasing amputation rates by 88% over the last 4 years has proved to be a success in a region that has been forgotten. And speak truth to power on topics that, you know, face you in medicine or whatever your specialty may be or your field. Just be bold and treat every patient like a family member. You know, we carry this apron of humility, which is the title of being an MD or a nurse. And the goal is to be of service to others and treat them with the best care that you can provide, and fight for the best resources to accomplish that. If it's policy action you have to get involved with, if it's local level, federal level, please roll up your sleeves, go and learn about your community, and let's try and enroll more African American, not only patients in trials, but also as you know, principal investigators, as PIs, so that they can learn about the communities and they can help teach other PIs and teach other patients as to what some of the structural issues that exist and how we can lead to transformation so that we can have a better healthcare system for all. So thank you for the privilege of invitation. I truly, you know, Kim, this has been fantastic. I know you're in the West Coast, so thanks for getting up early.
Of course, anytime. This was so worth it. And I appreciate you staying on so long. We were originally going to talk for 30 minutes, and we could talk forever, and I still would have more questions. So hopefully we could do this again. But if people want to find out more, they can go to PAD Advocate and you can get a hold of Dr. Fakarede, who's there. Also, your nurse's assistant is always willing to talk to you, Whitney, and any of his other staff. Amazing. We even had someone that chimed in right before this, and I loved how quickly you and your team just acted to get on the phone with her so she could save her mom. I really
Right, there are a lot, it's not just, there are a lot, I have a lot of teammates, both on-site and off-site. And also on Instagram, PAD Advocate is the Twitter handle, and Instagram, they can ask questions, and Cardiovascular Solutions of Central Mississippi is the Facebook page. So truly appreciate all the support, and thank everyone who's ever supported our program and our why. We truly appreciate that, and we fight for you, we fight for your families, and we'll continue to advocate for these communities, these underserved communities. And God bless everyone. Thank you.